and backwards if ever. So I rather do it with this, but I will need the mouse show. Huh? Yeah, fine, thank you.
So, good afternoon, everybody. I welcome you to the atrial fibrillation session. Also, on behalf of my co-chair, Professor Moore from London, from the Royal Brompton Hospital. Yeah. My name is Nicolas Stoll. I'm also a cardiac surgeon from Stuttgart. So, we just want to start, then we have more time for discussion. And I'd like to ask Professor Kappenberger from Lausanne. He's a cardiologist, and he will talk about basic principles in atrial fibrillation. He is a cardiologist, and I think it's always very important that we are open and that we learn from each other. And I'm very glad that you opened this session with basic principles for our surgeons. Thank you very much.
Thank you, Chairman, ladies and gentlemen, and thank you, Association, for inviting me to give this lecture on basic principles. The usual talk has to start with the definition, and many of my comments of today will, by the way, be based on the new guidelines of the European Society of Cardiology, the European Heart Rhythm Association, and your Association of Cardiothoracic Surgery. Now, they defined in this recent paper, I will give you the reference later, that atrial fibrillation is defined as a cardiac arrhythmia with the following characteristics. The surface ECG shows the absolute arrhythmia with irregular RR intervals. There are no distinctive P waves on the surface. These 2 points were certainly not of discussion in the past. The atrial cycle length, however, now for atrial fibrillation, whenever it's visible, is defined as less than 200 milliseconds, which means more than 300 per minute. So the gray zone to the flutter has maybe a little bit be obscured, eliminated. The prevalence of atrial fibrillation, and that's why the attendance is so high even if this late afternoon, the atrial fibrillation is the most common sustained cardiac arrhythmia occurring in 1 to 2% of the general population. The prevalence of atrial fibrillation increases, as you certainly know, from 0.5 in younger age to about 15% at age 80. Later than the age of 85, the recent onset of atrial fibrillation interestingly becomes less common. So based on that, it is estimated that at least this incidence will double over the next 50 years, according to statisticians, and according to surgical results, I'm sure it will then be reduced. For everybody in medicine, it is important, and for the general population, to know that the atrial fibrillation increases fivefold the risk of stroke, and 20% of all strokes are attributed to this arrhythmia. Now, the diagnosis, as I said, is based on an electrocardiographic recording, Holter or loop recorder or whatever is fine. The patient's history, however, is not a solid basis for diagnostics. Often, atrial fibrillation is silent. Palpitations can be AF, can be other arrhythmias as well. Heart failure can manifest atrial fibrillation, and atrial fibrillation can induce, for sure, a reduction in cardiac function. Over all the atrium, I calculated, is contributing between 20 and 30% to the cardiac output. And, of course, stroke is when we are too late with the history. The ECG, therefore, shows this typical non-visible the P waves. There is F waves sometimes visible, like especially in V1, where the vector is directed towards the left sternal border and to the right sternal border. But note that these are not flutter waves because they are less than 200 milliseconds apart. The arrhythmia absoluta, as also told, is well visible in this tracing. The main question nowadays is this an acute, a chronic, a paroxysmal, a permanent or persistent atrial fibrillation, and why does it fibrillate on that day in this patient? Is this with a visible or with an invisible basic problem? I will come to this later. That's why I do not cite the names of low nor based at this time. Well, the basic principle is, that's maybe a new approach, that atrial fibrillation has to be looked at as a symptom. Many different pathways can lead to atrial fibrillation, and the study of individual mechanisms is essential, as usual, in basic principles. Now, the classification of atrial fibrillation as it is now presented by the associations in Europe is that you can use the symptoms as a base. And when you see a patient, he presents either with the first episode, because we do not know his history, or he has repetitive episodes. If they are short-lasting, less than 48 hours, the individual episodes, then we call it paroxysmal. If these episodes are prolonged, may take over 7 days, then we call it persistent. If it is longer than a year, it is a long-standing persistent atrial fibrillation, and if we or the patient accepts to live with it, then it is called the permanent atrial fibrillation. Now, this classification is based only on history. The second point is that we look at the evolution. This has been really part of interest, and that we thought that there's a continuum. It often is, but not always, from a silent, as you see on the left of the slide, to a paroxysmal, to persistent, and then finally to permanent fibrillation. This is based on the hypothesis that atrial fibrillation in itself degenerates the atrial myocardium and improves or facilitates the persistence and of atrial fibrillation. Now, this evolution is often the case, but not always, and in many moments of this evolution, we can intervene. There is, moreover, a second point to look at. What is atrial fibrillation doing to the patient? And this is the new classification from the European Heart Rhythm Association, which relates to symptoms. You can have no symptoms, as I told, the silent atrial fibrillation. You can have mild symptoms, then it's ERA class 2, 3, or disabling, then it's 4. So using the last week published guidelines, you can have persistent atrial fibrillation class 1, which means the patient has it on the ECG, but he doesn't feel anything about it. But note that the symptoms are not related to the outcome. So we should not close our eyes before, even in front of silent atrial fibrillation. Now, the second chapter is about the pathologies that can lead to atrial fibrillation. So far, all the classifications ignore this, but we have to know that atrial fibrillation can be based on structural abnormalities, like fibrosis, which might be the reason why it is increasing in age, because in age fibrosis is increased. Inflammatory diseases, acute myocarditis, which can be extremely silent. Of course, rheumatic changes that lead also to myocarditis. Then we have the conduction abnormalities, like altered currents on the cellular level, on the membrane level, shortened refractory period, also as a consequence of altered membrane stability, reduced conduction velocity, which recently are related to the presence of different connexins, or rather the absence of connexin 43, etc. Then you have the well-known hemodynamic abnormalities like left ventricular dysfunction that not immediately must dilate the atrium, but increases the stretch on the atrial wall, and the stretch of the atrial wall is something that is really pro-arrhythmic and causes then the appearance of ectopic atrial activity, and we will see what that leads to. And last but not least, and probably at the beginning in many cases, is activation abnormalities like the sinus node disease, when the sinus node doesn't activate or too slowly activates the atrium, then it becomes electrically unstable, and atrial fibrillation can be a manifest, therefore, of sinus disease. Triggered activity means that there are anywhere in the myocardium ectopical foci that make the activity of the atrium at higher rates, like the automaticity, and then we have these newly described diseases of the ionic channels of the atrial cells that are then the manifestation of the congenital atrial fibrillation cases, or the hereditary atrial fibrillation. Now, the basic principle of the electric pathways underlying the phenomenon is that there are re-entry circuits that can appear if there is a pathological substrate, as I just told, the focus. rotors, as we will see, and the theory of multiple wavelets that maintain atrial fibrillation in itself, independent of important basic structural change. As a result, atrial fibrillation can be regarded as the coincidence of pathologies and initiating mechanisms. This is the electroanatomical coincidence, as I like to call it. With the following classification, you can have a simply electric cause, an electroanatomic cause, putting together what I just told you, are the purely anatomic structural lesion, as you see it in mitral valve disease, for example. Based on what I just told, we started many years to develop, together with the engineers of the technical high school, a biophysical model of the atrium, which I think is quite appropriate to explain you what I tried to tell you. You see that we have on the left the anatomic basis, which is a heart taken from MRI, and the atrium is isolated, can be reconstructed in 3D. And on the other hand, we have the knowledge from physiology and from the atrial cells. We can put these atrial cells into a grid, make a tissue modeling, and from there reconstruct an atrium with the anatomic and the electrical part of that can create problems, as I told you. Now, this atrium at the basis works at a regular rhythm of 60 beats per minute, but can be, of course, irritated. A normal heart or a normal atrium in the EP lab or in the model does not go into atrial fibrillation at the most a few seconds. However, if we stimulate the heart at a very high rate, as you see here, with 400 per minute, then suddenly this starts to fibrillate. I hope you saw it fibrillate, but it was surely too fast. That's why I slow it down. And you see now every second a sinus beat from this atrium, where you can distinguish here the pulmonary veins, the superior and inferior vena cava, the mitral orifice, and the tricuspid orifice. This model here, this is not a movie. This is a calculated tissue activation. Here are 300,000 cells, and in each cell, 16 different channel properties are calculated. Now you see that suddenly this focus near the sinus node is starting to burst. It's a high-frequency activation of the atrium, as it can happen after an excessive alcohol consumption. A normal heart wouldn't do anything wrong, but you will see that by the time these lines that go from here start to become independent, that they develop as rotors and as spiral waves. And now this will last on maybe a couple of hours or minutes, then it will be paroxysmal. If it stops spontaneously, as I showed earlier in the classification. Now here is another atrium, like you would find it with fibrosis. You see zones with different conduction velocities, and now the process of atrial fibrillation goes on. We see this type of atrial fibrillation, therefore, most often with fibrosis. This might not be the case in a localized myocarditis, like here, where near the basis of the left atrial appendage, you see clearly that there is a zone that has a rotor that is fixed to this singularity point, as we like to use it. And what you will understand is that these are different principles for the same disease, for atrial fibrillation, and yet at the moment still we think that we treat them by one technique only. This is the situation that has led to the therapy and the concept of ablation. Here the focus is placed very near to the pulmonary vein, or even in the pulmonary vein, And due to the turbulences that are created by the other pulmonary veins and the left atrium, this is a quite common origin of atrial fibrillation, and the goal in the ablation, where ablation began, namely to isolate the pulmonary vein. That was the cardiologic approach. We will come to the surgical approach right now. What Jim Cox has presented here 20 years ago was that he wanted to make small compartments in the atrium. These compartments should isolate the pulmonary veins, but also isolate different parts of the left and right atrium, so that there is not a space big enough to allow these re-entry and rotor concepts that I just showed you to evolve and to maintain. In our model, together with the surgeons from Lausanne, we tried then to evaluate how these lines work, and indeed, you see, to shorten my presentation, thanks to the surgical intervention that is simulated here on our model, atrial fibrillation stops. That's now what you have to do. It is just the tip that I can give you. These lines should be as intelligent and as short as possible, because everything that is line is destructed conduction and is destructed contraction. So in conclusion, ladies and gentlemen and dear colleagues, atrial fibrillation is a major health problem. Different structural, anatomical, and electrical abnormalities lead to different forms in atrial fibrillation. These different forms are, on one hand, based on the symptoms, on the other hand, dependent on the structural abnormalities that we see. Then we can name it. If we don't see it, then it is idiopathic or lone, as called in the past. Atrial fibrillation, therefore, is always a symptom of underlying problem. Basic principles are acute or chronic, initiating mechanisms, structural and electrical abnormalities. The biophysical model might contribute to further understand or to test eventually your hypothesis. If you have a new idea, you come to Lausanne Heart and you can test it. And this will help maybe one day to make a tiered therapy for each patient for his atrial fibrillation. Thank you for your attention.
Thank you very much, Professor Kappenberger, for this excellent and well-structured overview. So we have learned a lot again. And are there burning questions out of the auditorium? So maybe, may I ask you a question? So we have learned that the knife is not always the solution, and that the treatment of atrial fibrillation is a so-called stepwise approach from medication to cardioversion. And at the end of the food chain, you can find the cardiac surgeon. So I would like to ask you, as a cardiac surgeon, which patient would you transfer at what stage to surgery for standalone AF surgery?
It is, of course, a critical question. For me, the patient with refractory, highly symptomatic atrial fibrillation with an anatomy that is unsuitable for other therapies of ablation. I mean, the anatomy is so variable from patient to patient, with the different anatomy of orifices of the pulmonary vein, which make ablation difficult. I think at the end of this session we will hear the results, but you can anticipate in some cases that it will not work. And I think there might be a situation, especially with a minimal invasive approaches, that we come to surgery if we have also excluded the reversible origins, of course.
Okay. Thank you very much. So, do you have a question? Yeah, is this okay? So then we would like to continue with Professor Brown from Leiden, and he will